physician-assisted suicide is not necessary. If you look at the rhetoric advocating for assisted suicide, you'll see a strong emphasis on pain. This is an example of commentary from the Albany Times-Union advocating for assisted suicide by a cancer patient. She says, "What scares me the most is how I will likely die. My mother, youngest sister, and first husband each died in great pain and discomfort from cancer. Many nights, my sister Chris, who died at the age of 46, would walk around sobbing, sometimes screaming from pain. Nothing seemed to comfort her condition." Now that's clearly a sad situation. But I think Joan Gundrum and I would agree on that. But what we would disagree on is what is the solution to the problem. And I would also disagree with the claim that this is how she will likely die. Susan Block is a palliative care doctor, and she writes that more than 90% of cancer pain can be managed readily with simple drug therapies. If that's true, then it's not likely that a person with cancer will die in great pain. She does recognize that there are common barriers to achieving adequate pain control, which are basically access and the lack of expertise on the part of doctors. So I would propose that we solve those problems with education of doctors and increasing access to hospice. And I've talked with people about this over the last year or two, and sometimes people will bring up cases where they knew a family member who did die in great pain or suffering. And I'm not going to go into the details of each case with each person in order to try to prove a point. But I think on the whole, if you think about the cases that you in your life that you're aware of, there will be, and this is certainly true of the people I talk to, there was a lack of access to hospice. The patients were not on hospice and may have been treated by a primary doctor who was not as experienced as a palliative care physician. But if you're like me, you may say, well, I'm going to be in the 10% that the pain medications, the simple pain medications fail. Well, what do you do then? There are other options. Inpatient hospice is a prime example. Inpatient hospice is when you're admitted to the hospital for the purpose of treating the pain and other suffering. And there, the doctor can be much more responsive. You know, when you call the doctor when you're at home, it may be the next day that you get a call back. But on inpatient hospice, the nurse calls the doctor, and within 5 or 10 minutes, you've got a solution to the problem. And there are studies which document inpatient hospice is better at alleviating suffering than outpatient hospice. You can do lots of things to alleviate pain, like block the nerve, burn the nerve, stimulate nerves. There's a lot of new techniques, and there's even some new research into using ultrasound to treat pain. Although I have not seen that yet employed in palliative care in my researches, but I'm sure that it is or will be soon. Spinal morphine, so like an epidural, or even morphine directly around the spinal cord. Ask a pregnant woman how they felt after they got an epidural. You can numb up the entire body from the waist down. Palliative radiation and surgery, so focused radiation at the site of the cancer or cutting out the cancer. Or now there's even chemical radiation that goes through the bloodstream directly targeting the cancer, so there's not as many other side effects. And then finally, if all else fails, terminal sedation is an option, where basically you treat the symptoms, and as a result, you go to sleep or are unconscious and are not as aware of them. Inpatient hospice can be so effective that Dr. Michael Brescia at Calvary Hospital says, we treat 6,000 patients a year and no one, after they have been there for 24 hours, asks for assisted suicide. No one, no matter what's wrong, and we've seen some terrible cases. So that's a pretty strong statement of how effective modern palliative care is at alleviating suffering. And in fact, if you look at the reasons people are choosing assisted suicide in Oregon, suffering is low on the list. So inadequate pain control is only 26%, and that includes even people with concern about future pain control, people who are not presently in pain but are worried about it in the future. Loss of dignity and disability and loss of autonomy, and all of these are related to disability. It's the disability that makes you feel undignified and makes you lose the ability to do the things that you enjoy or want to do. Disability is the main reason, and the overwhelming majority reason people choose assisted suicide in Oregon, not pain and suffering. What we need is to support people in their disability and help them. So the suicide rhetoric almost seems like a bait and switch. It starts by playing on fears of intractable pain, claiming that that's common, when in reality, nearly all pain is treatable, and intractable pain in the proper setting would be very uncommon. Pain is not the most common reason for assisted suicide in jurisdictions where it's legal, and in fact, treatment of pain is not even required by the laws. The laws are not written as a last resort. In fact, physical suffering of any kind is not required by the laws in Oregon or the proposed law in New York State. So this almost seems like a bait and switch. If there's a problem with painful death, the first thing we should do is promote hospice, not suicide. Provide more education about how to treat physical symptoms to medical providers. But mainly, get people to Calvary Hospital and other places like it. Get people more access to palliative care services and hospice. And also support services like home health aides and respite care that can take some of the burden off of caregivers. I think that's the solution to painful and difficult deaths, not suicide.